And it is because patients with different cardiac disease are surviving for a long period of time, and we have an aging population. This is a major problem worldwide and in India as well. Now, mortality has also been increasing and keeps on increasing as there is aging population. In elderly population, the mortality is much higher. Now, what are the causes of death in heart failure? The causes of death failure are pump failure, sudden cardiac death, and rarely bradycardia and bradycardia. Now, as the severity of heart failure increases, the mortality due to pump failure increases. In class 2, we have sudden cardiac death as a major cause of mortality. In class 4, we have pump failure as a major cause of mortality. Now, NYHA class has been recognized as a major indicator of prognosis in these patients, both repeat hospitalization and mode of death. If we look at 5-year survival, as the NYHA class keeps on increasing, the mortality keeps on increasing. In fact, there is a 1-year mortality of 50% in patients who are in class 4 symptoms. Another major indicator of mortality which we have recognized is a QRS duration. It's an independent predictor of mode of death and hospitalization. As the QRS on ECG keeps on increasing, the mortality keeps on increasing. When they, the cutoff line is about 120 milliseconds. The mortality is directly relation to the duration of QRS segment. As the QRS increases, the mortality keeps on increasing. Now, we understand that there is a large percentage of patients have a wide QRS on ECG and have end-stage heart failure. In fact, 10% of patients have class 4 symptoms and wide QRS on ECG. And this is a segment of patient which we would be trying to tackle today. Now, why do we need a new modality of treatment in heart failure? 40% on medical treatment are not suitable on ACE inhibitors. 60% get rehospitalization, and it is an important cause of mortality. And despite optimum medical treatment, mortality continues to be high in class 3 and class 4 patients. Now, this is how the heart failure progression occurs over a period of time. And we have a modality of treatment for these patients who are non-responsive or who are on an optimally medical management, and we call it cardiac resynchronization therapy. Now, the CRT, to be short, is useful in patients who have moderate to severe heart failure, NYHA class 3 and 4, who are symptomatic despite optimal medical treatment, who have a QRS prolonged more than 130 millisecond, and who have a left ventricular ejection fraction less than 35%. And CRT-D, which is we call it the combo device, is useful in all those patients, including indication for an ICD. Now, treatment for heart failure has been there for a long period of time, and way back in 1988, for the first time, it was shown that in addition to controlling symptoms and preventing heart failure, drugs could prolong life in these patients, and the first drug to be useful was ACE inhibitor captopril, and since that time a number of drugs have become available, beta blockers as a group, ACE inhibitors, spironolactone inhibitor, and those drugs have been found to be useful. And if we go back from 1988 onwards, we find that the use of these drugs has decreased mortality. Beta blockers decrease mortality, ACE inhibitor mortality, decreased mortality, and when we add a CRT-D to these patients or drug treatment, mortality gets further reduced. Now, we look at mortality and hospitalization, beta blockers reduce it, ACE inhibitor reduce it, and CRT reduces it still further. Now, when we talk of desynchrony of heart, we are talking of atrioventricular desynchrony, interventricular desynchrony between right ventricle and left ventricle, and an intraventricular desynchrony between the various walls of left ventricle. Now, how does desynchrony produce a heart failure or worsen heart failure? Atrioventricular desynchrony decreases ejection fraction, cardiac output, increases left ventricular systolic volume, increases mitral regurgitation. Atrioventricular desynchrony increases left atrial pressure, decreases left ventricular diastolic filling period, increases left ventricular end diastolic volume. Interventricular asynchrony decreases the right ventricular store volume and cardiac output, and all of these factors increase the left ventricular end-systolic volume, increase the left ventricular end-diastolic volume, decrease ejection fraction, cause inactive remodeling, and produce heart failure. And when we're talking about resynchronous therapy, this reverses all this progress and causes a positive remodeling, improving left ventricular ejection fraction and cardiac output. Now, we have been using cardiac resynchronization therapy for the last about 10 years, And initially, what was found was that this is useful is improving symptoms, and as more experience came up, larger trials showed that it not only improves symptoms, prevents hospitalization, but also has a beneficial effect on mortality. The first time the initial trial showed that the cardiac therapy is effective when the left ventricle lead is placed at a site where the latest stimulation takes place. And we today know that what is the optimum site for causing maximum benefit in these patients. It has also been shown in trials that there was functional improvement with use of CRT, the 6-minute walk time improves, and the hospitalization decreases. But what is the most important is that improvement in mortality in these patients. And companion trial was one large trial which showed that once we use CRT and CRT-D, there is a 40% reduction in mortality over a period of time, which is very, very significant. This showed that all the endpoints, primary endpoint, hospitalization was much less with CRT, mortality was much less, and all-cause mortality was decreased, showing that it improves survival in this group of patients. If we look at the meta-analysis of various trials which have been carried out, it showed that overall, when meta-analysis is carried out, there is a mortality benefit of using CRT in these patients. Now, when we implant a CRT, there are a few differences from general pacemaker, because it's a little different from the conventional pacing. It's a little prolonged procedure. We have to use left-sided as compared to right-sided approach. We need a longer fluoroscopy, multiple angulations, and different people use different skills for this. Most of them use an angioplasty procedure, angiographic procedure. Some use an electrophysiological technique to do it. And a team approach is absolutely important to have a long-term good outcome. It differs from the conventional pacing because we need to access the coronary sizes to stimulate the left ventricle. So different types of guiding sheaths are required. We need to visualize coronary sinus anatomy very well so that the different branches can be outlined, and we can choose the optimum vein for implantation of the left ventricle lead. The left ventricle lead is specific and needs special handling, and the right ventricle lead has to be placed very adequately. Now, in the group of patients where this treatment option is used have a few problems, because elderly patients, there are patients where the cardiac chambers are enlarged, the right atrium may be quite hugely enlarged, making this coronary sinus a little difficult. The coronary sinus anatomy may be a little variable, coronary venous sinus anatomy may be variable. The patient may be post-surgical, so there a lot of scar is there, so anatomy may be altered, or there may be, because of myocardial infarction, there may be a lot of scar, and one may have to find out an area which is viable so that stimulation takes place very well. We understand today that the left posterior lateral ventricle branch, which is in the area of the circumferential territory, is the area where we need to stimulate, and that is where we try to go. And this is how the coronary sinus anatomy looks like. This is the posterior lateral ventricle branch which we want to stimulate. Very little effect is done if the great cardiac vein or the middle cardiac vein is stimulated. So we have to have an optimum vein for stimulation and try to go as distally as possible to have the maximum effect. Now, there are little problems with the CRT. It's not there are technical issues, and sometimes we may not be able to access the coronary sinus. Occasionally the phrenic nerve may get stimulated, and sometimes we may not have a good optimum position of the left ventricle lead. Now, the potential complications this procedure are that we may have a high threshold, and one of the important causes is old myocardial infarction and scar. We may occasionally have problem with coronary sinus. It may be dissected in 2 to 3% of patients because the guiding catheter has to be very specific, and so there can be problem with coronary sinus dissection. Phrenic nerve stimulation, because that's very close to the site where we stimulate, can be a major problem, and that needs also to be tackled. Now, the summary of worldwide experience is that CRT in patients who are not responding to optimal medical treatment improves functional class, decreases hospitalization, improves quality of life, and improves survival. But the most important thing is the choice of patient who would benefit on this treatment modality. And efforts are on to identify non-responders pre-procedure so that this procedure can be avoided in those patients. Now, what is the experience we had? I started doing CRT in 2007, and the last 4 years have been very productive, very stimulating. And we had about 48 patients who have undergone these procedures. Majority of them were male. The oldest patient was 78 years with a mean age of 62 plus minus 12 years. Now, a large majority of people, 95% of these people were in class 4 and 5% were in class 3 symptoms. Now, if we look at the pre-existing disease in these patients, 33 patients out of 48 had hypertension, 21 had diabetes, 30 had a previous bypass surgery, 6 had a previous angioplasty done, and some of these patients already had a pacemaker. 5 of them had pacemaker, 3 for dual chamber pacemaker, and 1 VVI and 1 VDD pacemaker. Now, out of these 40 patients, etiology, ischemic cardiomyopathy was present in 25 patients. 22 patients had dilated cardiomyopathy, and 1 patient has severe aortic regurgitation with severe left ventricle dysfunction. Now, ECG in a large majority of patients showed a left bundle branch block with QRS prolongation. 1 patient had a right bundle branch block, 2 had non-specific intraventricular conduction defect, 3 patients had complete heart block, and 3 patients were in atrial fibrillation. The QRS duration was, as expected, was prolonged. The range was 0.13 to 0.2 seconds. The range was, the median was 0.14 seconds. Now, if we look at the ejection fraction of these patients, the average ejection fraction was 22 plus minus 6%. The range was 12% to 32%. 22% had regional wall motion abnormalities. 10 had regional wall motion abnormality in 1 single coronary artery territory, and 12 had in multiple coronary artery territory. Left ventricular and diastolic volume and systolic volume was significantly dilated in these patients. Mitral regurgitation present, mild was present in 11 patients, 25 had moderate mitral regurgitation, and 12 had severe mitral regurgitation. As I said, 1 patient had severe aortic regurgitation. 40 patients had tricuspid regurgitation, 11 had severe pulmonary artery hypertension, 25 had moderate pulmonary artery hypertension, and 4 had mild pulmonary artery hypertension. Now, type of patients, 65% were given a CRT-P, which is a biventricular pacemaker. CRT-D, which is a combo device, or a CRT plus an ICD, was given in 35% patients. Now, complications were few. In 5 patients, we could not get an adequate left ventricle lead placement, and my surgical colleagues were very, very kind enough to put a transthoracic lead in all of these patients. We did not see any patient who had a coronary sinus resection or a pacemaker site hematoma. 1 patient had pneumothorax, which reverted back to normal with the tube drainage. 4 patients had phrenic stimulation, and 2 patients had modification to current treatment in this phrenic nerve stimulation. Now, we have a follow-up which is up to 42 months, and 32 patients showed an immediate improvement, QRS duration decreased, and mean arterial pressure improved in this patient. 40 patients were responders and 8 were non-responders. 5 patients died on follow-up, 2 of recurrent heart failure, 1 sudden cardiac death, 1 possibly pulmonary embolism, and 1 hyperkalemia. So, there is a significant improvement in a large majority of these patients. It shows the functional class of these patients. 30 patients are in NYHA class 1, 65% in NYHA class 2, and 5 patients are in class 3 patients. Now, survival, we had 10 patients who have survived for 3 years, 46 patients had survived. This includes the survival, these 10 patients also. 46 have survived more than 2 years, and the survival was 82%. Now, in conclusion, I would like to say that heart failure is a major problem worldwide, and in India also it is reaching an epidemic proportion. We need large multicentric studies to find out the utility of this treatment modality in India. And they should also look at the socioeconomic condition, because cost remains a major factor in giving this treatment modality to this patient. And we need a large database of CRT in India, as a awareness for this treatment modality is not there. Cost is a major problem, and our study of 48 patients over a period of 4 years shows that in a select group of patients with intermediate term follow-up, CRT is beneficial, and larger studies are required for follow-up. Thank you. Thank you. This is a team approach, and these are the patients who have got biventricular therapy, and team has been very useful in helping us in performing these patients. Thank you. Thank you for your kind attention. A problem with the coronary sinus anatomy, and there have been data to show that if a CT is done before the procedure, then you can pick up these anomalies, and you can also find out which particular vein to access at the time of procedure. But we have not been using this modality in our patients. But out of 48 patients, we had 5 failures, and our surgical team was useful in helping us out of this difficulty.
Should
So
you,
I think a CT can be a useful modality to choose these patients before the procedure.
if you fail the coronary sinus, do you send the patient to the surgeon to put the lead by thoracoscope or something? If you cannot put the lead through the coronary sinus, do you send the surgeon?
Yeah, we sent
or-
a surgeon. All these 5 patients had a surgical on the same day. In fact, from the cath lab, they were taken to the theater and they had a transthoracic placement of the epicardial lead.
In general, how long the effective of the coronary synchronization therapy after the treatment? How long it lasts?
See, if you look at the benefit, 30 patients showed an immediate benefit. At the time of doing a procedure, the mean arterial pressure rose, the QRS restoration came down, and we had echocardiographic benefit over a period of time. We have longest follow-up is 42 months in these patients. So during that period, we have found that benefit loss. But there are limitations that basic disease progress may continue to progress. So we need a longer term follow-up before we can say. We're not, we're saying that some patients may be non-responders, and we are trying to identify what are the features which indicate these non-responders. If the choice of patient according to the criteria which we use, functional class, ECG criteria, and echocardiographic desynchronization, then the non-responders are much less. But the basic disease progress may take place over a period of time, so we need a longer term follow-up.
Okay, thank you.